Hi, I'm Dr. Derek Lee. I'm happy to introduce Dr. Noelle Larson, who is a pediatric orthopedic surgeon at the Mayo Clinic in Rochester, Minnesota, as well as Shriners Children's Twin Cities. Welcome, Dr. Larson.
Pleasure to be here.
A question I want to ask first is basically, are your roles different at the Mayo versus Shriners? How does that work?
It's a different facility.
Mm-hmm.
I actually was going there prior to taking the job at Mayo. I worked for a year at University of Minnesota, and Mayo allowed me to continue to do outreach there. So I go 1 to 2 days a month.
Okay.
Unfortunately, they recently closed their operating room, so I'm not operating at Twin Cities Shriners, but I do see patients there. But it's the same job. But it's fun to have two facilities and to have, actually for a while I had quite a few Canadians at Twin City Shriners.
Okay.
We covered kind of the mid portion of Canada because the Shriners hospitals, I believe, are on the coasts for the Canadian Shriners hospitals.
Oh, that's interesting. Okay. It's unfortunate they stopped surgeries. Okay.
They have surgery available at Gillette in Minneapolis. But the downside of that is that if people are from outside of the US or without insurance, it's a little bit more of a struggle to get them in.
Okay. Now, when I was doing a little bit of research on your bio, it was pretty amazing that you went to Stanford for physics, and then you switched completely to becoming an orthopedic surgeon. Can you talk a little bit about that transition and what kind of triggered that movement into medicine as opposed to continuing in physics?
I think it's not an uncommon pathway for orthopedic surgeons. Many orthopedic surgeons started out in physics or engineering and then had a change of heart. Basically, I spent a summer doing geophysics as an intern, analyzing seismic data, and realized I did not want to sit behind a computer the rest of my life. And I met several other pre-med students actually on that same internship and said, that's the life for me. And then it was really a delight to find orthopedic surgery, which merges both kind of the engineering and quantitative component plus the people skills. So I feel very fortunate and privileged to be a pediatric orthopedist. And as much as the background seems disparate, it all kind of fits together in my own world here.
Very good. Now, with physics, I know it's kind of male-dominated. Orthopedic surgery is as well. Were any particular challenges working and learning in those two different environments?
Everyone has always just treated me with the utmost respect. Mm-hmm. And I was an only child, and I grew up in a boatyard. And I think my father wanted a son. My mother was extremely girly. So I think I've really been exposed to everything. Okay. And had the privilege of being able to fit in a lot of different worlds. But there are more men than women in orthopedics, and I think orthopedics is a great field. So it'd be great to have more ladies. So please come join us. Okay. Don't be afraid.
We'll put the word out with this interview for sure. Now, I was also diving into some of the research you've done, and with respect to pregnancy and fusion. And just to quote one of your studies, in quotes, back pain and outcomes of pregnancy after instrumented spinal fusion for AIS. You kind of drew some conclusions with respect to when women were fused lumbar down to 3-4, L3, L4, they tend to have a higher incidence of low back pain and actually with cesarean sections compared to non-fused or fused but not being pregnant. Can you talk a little bit about that study?
Right now, I would say this is an area of inquiry, and all the work we've done on this so far is rather preliminary. So there's a surgeon, Dr. Grabala in Poland, who is interested, and then Dr. Sukin Shah at DuPont is interested in this topic. So we've worked together and pulled some data. It's quite hard to do these long-term follow-up studies. So I have found a cohort of about 150 patients who were treated at Mayo with minimum 20-year follow-up. So reporting on the pregnancy outcomes was a subset of those who had deliveries basically still here at Mayo Clinic in Rochester. And we found a trend towards higher C-section rate in patients with scoliosis, and then a trend towards higher C-section rate with patients that were fused lower into the lumbar spine. But I would say I do not recommend maybe sharing this as a tried and true conclusion at this point. I think we need more work on the topic, and that was my primary aim maybe of the publication, to at least start talking about this question, most women end up having children someday, and then most people with scoliosis are women. So I think this is a reasonable area of inquiry.
Do you have any other studies in mind that you might broach with respect to that particular topic?
Well, it'd be great to do something prospectively. I think that would involve a collaboration with our OB department here. So it's on the list. Okay. But if someone else wants to work on this topic, I'm happy to support them. And I think it's hard to do these long-term outcome studies, but very worthwhile, because we make changes to a child's back and they're going to live hopefully for another 70 to 90 years. It's important to know what the long-term effects of our current treatment are. Okay.
Just a follow-up question to that. Do you have any kind of sense or inclination or inkling why, for instance, there might be more C-section in a fused and pregnant population compared to others?
I think it's complete speculation at this point. It may be more difficult to do a spinal injection or epidural for pain relief. However, the effect of an epidural on C-section versus vaginal delivery is also debated. Some people think having an epidural makes it more difficult to deliver vaginally. Could be concern on the part of the OB that there's this fusion history and there's a big incision on the person's back and they're more willing to pull the trigger for a C-section. Or there could be some kind of structural difference, right? The person's not able to, fire the musculature to deliver the baby in the same way. It's plausible.
Sure. Yeah, lots of things to think about. Now, staying on the same topic in terms of, have you noticed any correlation between, well, let me just reverse a little bit, because some people, I don't know if it's actual truth or not, feel that, as women age and specifically go through menopause, hormonal changes, there tends to be perhaps an increase in pain due to scoliosis or a progression in curve during that time. Have you noticed any trends or research on that topic?
I think there's a lot that needs to be unfolded as far as bone health and scoliosis and risk of curve progression. There's been some very nice work by the Hong Kong group, and I believe specifically Dr. Lam, who has shown that children with idiopathic scoliosis have lower bone mineral density compared to patients without scoliosis. And then also fancy CT scans of the wrist, the patients have worse bone quality compared to those without scoliosis. And some indication that treatment with calcium or vitamin D might improve these metrics. A little unclear if treatment actually prevents curve progression. But it's back to this problem with the long-term outcome studies. Most of our long-term outcome studies are 30 to 40 years, and that only gets the child to 40s or 50s years of age. And a lot of the patient population that we see with degenerative scoliosis or progressive scoliosis or postmenopausal, and we really just don't know what happens. But it makes me worried if someone has a 40-degree curve and they're 50 years old and then their bone health deteriorates with age, as it does for all of us, what's going to happen to their deformity? Okay. So hopefully we'll develop some drug that cures scoliosis, and then we don't need scoliosis surgery anymore, and maybe it's all a metabolic problem, but we don't know quite yet.
Okay. Let's switch to a couple topics. I want to definitely touch on ApiFix and on tethering as well. When was your first exposure to vertebral body tethering?
I was reading abstracts or proposed research presentations for the Scoliosis Research Society around 2014. And I noticed that unlike the stapling procedure, the tethering procedure was having a problem of overcorrection. And in my mind, overcorrection is just an indications problem. It's working too well, and it is a viable technique. So I became pretty interested, and I visited my colleague, Dr. Pays at Philadelphia Shriners, and then we did our first tether at Mayo in 2015 using Dean Assist through the off-label approach.
Okay. Do you have a general number of VBT surgeries that you've done at Mayo and I guess previously at Shriners? Twin Cities?
Yeah, unfortunately, I have not done spine surgery at Shriners just because of the geographical limitations. It's 80 miles away.
Okay.
So if I'm doing spine surgery, I usually like to be in the immediate area for the postoperative course. But I do see a lot of spine patients there in clinic. But we've done about 73 at Mayo. So we've done 73 tethers. We did about 10. And then at that point, I felt like I really wanted to collect data on these patients. And we submitted a 1,400-page application to the FDA and completed a surgeon-sponsored investigational device exemption study. And that process took about 85 conference calls with the FDA and 6 months, and it was approved in April of 2018. So we have 40 patients of those 70 who are enrolled in a prospective IDE FDA trial. We've completed enrollment on that, and we're following these patients now for 2 years. And then since then, a year ago, Zimmer, the Tether system, became FDA approved, and we've been enrolling patients in that post-approval study. So nearly all of them are captured in a research database, which I think is very important so that we can learn from each other and avoid making the same mistakes at every single center in the US and share our information among ourselves to bring the science forward.
Absolutely. The more data to prove or disprove the procedure, it's the scientific method, right?
I'm pretty data driven. It must be that physics.
You sound like you're administrative and form driven as well in terms of applying for these things.
I've had some really, really, really good helpers at Mayo. Otherwise, it would have been nearly impossible.
So much time, eh? Oh. Okay. Now, in terms of the tethering that you do at Mayo, is it primarily thoracic, or do you also move into the lumbar region?
We've always done thoracic and lumbar here. Early on, we started out with one of our adult minimally invasive spine surgeons. So the approach to go to a lumbar disc is very similar to the approach to go to a lumbar vertebral body. And subsequently, we've transitioned to doing more of a mini open. Interestingly, the incisions were about the same size for a tube approach versus the mini open, but we can see a little bit better without the tube. So we've done lumbars, but probably 3 times more thoracics than lumbars. Okay.
Have you, with respect to some of the surgeons like Peter Newton, for instance, he's done quite a few hybrids where selective thoracic fusion and lumbar tethers. Have you guys tried any of those particular techniques, or are you just doing straight tethering right now?
We have not. We have not. We've done double tethers, but I feel like if families are interested in the tether, they typically want to go all the way and are trying to avoid the rods. And if we feel like that's a reasonable potential, we'll do whatever we can to try and avoid a fusion.
Okay. And double tethers primarily in the lumbar region?
Well, like right thoracic, left lumbar. Okay. So we do 2 tethers. Yeah, there's different meanings for that. So I have always done 1 tether cord. I know some centers are putting in 2 tether cords. I feel like instead of putting in 2 cords, we need to design a better cord. Because when you're putting in 2 cords, you're subjecting the patient to twice the risk. We have to place 2 screws, 2 cords. It adds to the surgical risk in my mind. So, I mean, just from an engineering perspective, someone just needs to make a better cord. I'm not going to put 2 in. That seems silly.
So since we're on that topic, have you heard anything from Zimmer regarding stronger cords coming out?
No.
Okay.
But I'm hopeful, right? And maybe some other companies too. There's other groups that are working on this problem.
Yes. I'm trying to contact Globus, and I talked to Dr. Perron about the Scoliosis tether as well. So there are new tethers coming out. We'll just see what the engineering is and the material science, I guess.
I'd say for cord breakage too, it sounds very scary, and the FDA thinks it's very scary. But from a surgeon perspective, if the x-ray looks okay and the curve is reasonably corrected and the patient is balanced, it's not necessarily a failure. And in some ways, if the cord breaks, that may restore even more spine motion. And if you think of the tether as an internal brace, once you're done growing, maybe you don't need that cord anymore. So, and families always ask, does it hurt if the cord breaks? And I'd say mainly it's a scientific radiographic finding. And as long as the curve is in an acceptable alignment on the radiograph and the patient's asymptomatic, we're safe to observe.
Yes, because tether breakage is not necessarily a bad thing at all. And I know from talking to surgeons like yourself that they actually hope for multiple breaks once maturity has hit, in terms of the spine isn't growing anymore. So it frees up greater range of motion.
That's the concept.
With VBT or tethering in general, there's a spectrum of surgeons. Some are a little bit more towards the mature end, and others are more at the immature end, depending on bone growth modulation. Where are you on the spectrum?
Well, it's a moving target, right? Our FDA study had fairly strict criteria, so it was Sanders 4 or less, so some type of open growth plate on the fingertip, and hopefully correlating with 1 year of growth remaining, or RISR 2 or less, one of those two criteria. Again, shooting for about 1 year of growth remaining. Now, there's a couple more publications that have come. And again, all surgeons are humans, right? So we have the data, but we're also emotionally driven. So having seen my patients and seen how well they do with the tether, and had that enjoyment of watching them return to sports more quickly and coming back to clinic and saying, how do you feel? They say, I feel normal. It's really inspiring. So I think we have creeped up for sure to doing Sanders 5 in the last year or so. And then there's 2 new papers now that came out, one from Ohio and one from Turkey, that had some very mature patients. So I think it's still kind of this shared decision process with the families. And if it's an older child with a smaller flexible curve, that might be a tether candidate. If it's a younger child with a bigger flexible curve, then I think we're more eager to jump on board. But at any rate, the data is slowly growing. I think technically there's nothing that would stop tethering in someone that's mature if it's a flexible curve and if the cord is durable. But at what point do we reach that level where it's safe to ask families to undergo the procedure? It helps that there's at least a handful of people in the literature, because prior to the last 2 months, there were no published reports of a fairly mature patient undergoing anterior spinal tethering.
Yes, I read those studies actually, and it was pretty interesting that it seemed that they were getting a little bit better correction somewhat and less tether breaking, which was kind of counterintuitive to what you would expect for the more mature spine.
I think that's the same thing I drew from that data as well, and I made a little table, and it sure seems that you need to get 50% correction. So the curve needs to get less than 30 degrees on that first direct x-ray. And then probably less than that is maybe associated with a higher failure rate.
Yeah, it's hence the moving target in terms of that spectrum, right? So it's, yeah, that's pretty interesting that as far as parameters, they seem to be expanding a little bit. Now, in terms of your perfect VBT patient parameters, what would you say they are?
I guess it depends on what you're trying to get out of it. I mean, the patients who are most likely to benefit are these very high athletic participants, right? I mean, the people that are doing backflips and handsprings and use every single degree of motion in their thoracic spine. I mean, those are, I think, the most likely to benefit. Right now, I'd say our indications are 40 to 65 degrees is the FDA indication. And then skeletally immature, which is the FDA indication. The bigger the curve, the younger the child that you would wish to have. So you want to have it matched. And eventually this is all going to be part of a computer algorithm that's not yet available to us. But again, the Montreal group has worked on trying to get a predictive model going so we know not only when to do the surgery or who's a good candidate, but also how much to tension the cord. Because intraoperatively, there's a bit of a surgeon choice of how much do you tension the cord. And I think some of the overcorrections could certainly be avoided. And it's just surgeons on their learning curve trying to figure out what type of correction we need given the patient's age.
Now, when I started researching scoliosis surgery and non-fusion techniques, initially with, I guess I ran into the biomechanical degeneration or the progression of scoliosis with RASO, where you have anterior wedging of the vertebra over time, leading from kyphosis to hypokyphosis, the lordosis, and then the spine, just to reduce tension and reduce the anterior column, rotates. Then you get the traditional scoliotic curve. But some of the surgeons I'm talking to lately feel that that is true, but when you have rapid growth, it's more of the disc wedging that they're seeing. And I know it's a couple motion with the disc and the vertebra. Do you kind of see it as more of a disc issue as well, or is it kind of a bit of both, I guess?
Yeah, I mean, I have a lab studying the growth plate, so I'm a little biased. I guess we
Okay,
study the disc. I guess we study the disc too, but I think the growth plate is probably where we can do more modulation.
Mm-hmm.
And the growth plate is where we target limb deformity correction with these little guided growth plates that we use to correct knock knees. But at the end of the day, I don't know if it really matters. I know the complaints with the tether are that it doesn't really affect the sagittal plane. It doesn't affect the side view. It doesn't help a patient with a flat back develop more rounding. I think it's a little too early to say. I mean, the early reports are fairly limited number of patients. For sure, in my practice, I've seen that the right thoracic prominence, if it's not too large, does seem to improve with the tether over time. Like that right thoracic prominence can improve, by upwards of 50%. So for sure, it's helping with the rotation in the right patient. I think almost the disc versus the growth plate is a higher level question that's going to be important down the line, again, when we have drugs to treat scoliosis.
So you're saying you can select, if you might have a drug, then you could selectively target the growth plates and maybe change growth at certain phases?
It's my dream, but
I like it.
Kind of a long shot. Yeah, it's kind of a long shot, but and I'm a little bit pulled between the research science and then the clinical science, right? Because I'm much better at the clinical science and it goes much more quickly, and I have patients right in front of me. But that'd be cool. If someone else wants to work on that, I'm happy to work with you, and try and cause pharmacologic growth plate modulation.
Okay, we'll have to get the pharmaceutical companies involved.
Yeah, more regulation, huh?
Absolutely. Going back to the growth plate and the disc, can I get your perspective on disc release and for immature spines and mature spines, and trying to correct larger curves? Because again, there's a spectrum where some surgeons feel that you shouldn't be touching the disc because it's going to lead to faster degeneration. Other surgeons are going with rigid spines and large apexes that the discs are already degenerated to a certain extent anyway. Where do you fall on that spectrum as well?
For sure. I actually had a grant last year to do an animal model of disc release, and my postdoc did a literature review of animal models of disc degeneration, and we decided that had been done to enough animals in the world, and that the topic was pretty much established that a disc release causes disc degeneration. The other piece of information I'd like to share is that it's hard to know exactly how much the spine moves after tethering. So in our tether patients, we have done bending films as standard of care 1 year after the tether procedure. And on average, we have 10 degrees of side-to-side bend and 20 degrees of flexion extension, sometimes up to 40 degrees through the thoracic spine, which is similar to what's been reported in normal adults. As far as 20 degrees of thoracic spine bending and flexing and extending. I would bet if you x-rayed normal children and looked how much the thoracic spine moves in a normal child, it moves even more, particularly these gymnasts and the like. So I think the question is, if you do a disc release, does the spine still move? So really all these patients who've had disc releases, we need to do bending films at 1 or 2 years after the surgery and see if there's any motion that's preserved, or has that disc release gone on to basically an autofusion? So I think there's work to do, and I'm just not quite comfortable releasing the disc in a normal human child at this point. But I am comfortable doing fusion surgery. So I know many people feel like fusion surgery is, you know, similar to a disc release. But at least the fusion surgeries have been done for the last, you know, 40 years and are considered standard of care, and I'm pretty good at it. So I think I don't feel confident with the disc release yet. But again, if someone publishes some data and we learn more about it and shows that it preserves motion and function, I'm not opposed to it. But it's just really preliminary right now in my mind.
Okay. And even the definition of disc release seems to be a moving target as well. Because for some surgeons, it's the annulus is incised. For others, the nucleus is removed. And for others, the anterior longitudinal ligament is released with the anterior release. So what's your definition of disc release?
Again, just a little bit of background. There's a nice study out of Mayo, actually, where they were doing fusion surgery of the neck from the front part of the spine. And as we do a fusion surgery, we put a needle in the disc and check an X-ray to see what level we're at to make sure we're removing the right disc, just to localize. And so then they did a follow-up study of those patients that had a one-level neck fusion, and they also recorded what level the needle was placed in. And patients who had a needle placed in the disc had like an 8 times higher rate of degenerative neck disc disease from having a needle placed in it. So discs are very sensitive.
Yes, because I know surgeons refer to the animal model that did a similar thing in terms of with a needle test as well. Okay, I wasn't aware of that at all.
Human cervical discs too. So it may not take that much to irritate a disc. And disc disease is the #1 global cause of disability, at least prior to COVID. Worse than malaria, cancer, heart disease. If you look at human disability in the whole world, disc disease is #1.
Okay.
So I don't want to contribute to more disc disease.
In talking about data again, have you, and you've been collecting data for the study, the study with VBT and 70 odd patients. All the surgeons basically capture data in terms of tether breaks, revisions, overcorrections. Can you share that data with us as well?
Sure. I think if we want to drop down to like idiopathic patients, because let's just focus on the idiopathic patients. So we've had one patient whose lumbar curve progressed, where we had to go back and tether the lumbar curve. We've had one overcorrection. Okay. So those are the 2 reoperations we've had. And we've had also 2 patients at 1 month after the surgery who came back with chest pain, and they had reaccumulated fluid between the chest wall and the lung and needed basically like a needle drainage of that fluid under anesthesia.
That's pretty amazing. So 3 over, yeah.
But I'm not at 2 years. I'm not at 2 years.
Okay.
And right now I'm just slowly starting to publish on some of these side questions like length of stay and blood loss. Okay. But really right now, to be in the respected literature, you need minimum 2-year follow-up to publish something in this field.
Okay. Now, what guides you in terms of when you're tethering, in terms of trying to figure out how much tension? Because it seems to be such a surgical decision, experienced decision. Some of the surgeons I've talked to try to judge correction based upon if they can realign the discs, right? Do you go through a similar methodology, or how do you approach making that decision?
We have a little bit of a different approach at Mayo. For the fusion surgeries, I have navigated all my pedicle screws. So we obtain a low-dose intraoperative CT scan, which is about the same as a 2-view X-ray study. And then I can watch all the screws go in on this cartoon. So I have done the same for my tether surgeries. And so I can see, again, exactly how long to make the screw and exactly where the spinal cord is. And again, this is like with my overall desire for perfection. So because of that, we don't have intraoperative fluoroscopy. So I'm not taking X-rays and judging the disc width in real time. So basically, we give it our best shot, and then we check an X-ray. And I think that probably ends up on less radiation exposure net
Right.
because we're not doing intraoperative fluoroscopy. I have a whole lot more information from that low-dose CT scan than you have from fluoroscopy from two-dimensional images. And so then we do a couple other things. So to get the correction, we tension the cord. We also bend the table. So we have kind of this spine deformity table that bends.
Mm.
So intraoperatively, I bend the table, and then we're not putting tension on the screws. We're putting tension on the patient's body. So I think that improves our tensioning ability. And we just looked at a series of about 60 of our patients. And basically what we found is our preoperative bending film correlated very, very closely to our first erect image. And then our intraoperative x-ray was about, on average, 10 degrees better. So say you started out with a bending film, you had a 50-degree curve, it bends to 25. Intraoperatively, it's going to be 15 degrees on our x-ray. And when the child stands up, it's going to be 25 again. So that data has helped us quite a bit. In the younger child, I'm shooting for more correction. And in the older child, or excuse me, let me back that up. In the younger child, I'm shooting for less correction. In the older child, I'm shooting for more correction. I'm getting more and more comfortable with that intraoperative x-ray. And if we're not happy with the amount of correction, I'll go back in and tension some more. Or if I think we've overcorrected, which is often true with a lumbar curve, then I'll back off on the correction a little bit intraoperatively. But I think it's maybe 15% of the time that we have to tweak it. I had one other thought. Let me think for correction. Oh, this is really getting technical, so I don't know if your audience is interested.
Yes, they are.
Okay, but really we want to correct over the apex, right? So you want to tension maximally over the apex, and tensioning at the top and the bottom, I think, can cause adding on and progression of the lumbar spine curve. See if you're doing a thoracic tether, if you overtension the bottom level, you can cause lumbar curve progression.
So many variables to think about.
There are, and unfortunately, it's still kind of an art, not a science. So that, I think that's the other thing. I mean, I'm really glad we have this FDA approval, but it seems that many surgeons around the U.S. are getting trained in how to do the tether, but my impression is that many of them are just waiting, which I think is perfect. If the regional surgeons could kind of wait a year, we're going to have a lot more publications out there and a lot more data and better advice to kind of talk new surgeons through as far as how to avoid the learning curve.
Okay, and even parameters, again, with those two recent studies within the last 2 months.
Exactly.
Is that, if you could go a little bit into the table you do to basically, is that just with your Mayo facility or center, or is that done at other centers in terms of helping to?
I don't know of anybody else doing it,
Yeah.
and I think Dr. Alanay is navigating his tethers in Turkey, but I don't know anybody else that's actually navigating the tether screws. And I don't know actually how much it contributes. I don't know how much pulling on the cord versus bending the table makes a difference, but we're still just doing it all. And again, surgeons are a little bit superstitious. You know, we have our special socks and we just do everything. No, I don't. but we do everything the same way because it's gone well. And we hate to change any variables unnecessarily. And if we're going to change things, we tend to do it in a very kind of graduated fashion. Because patient safety at the end of the day, right? If you do something different and suddenly there's a problem, it weighs heavily on our conscience.
Okay, makes sense. Because I've heard other surgeons state that you know, when they tether, let's say a thoracic, and the vertebra is so much smaller in the upper thoracic compared to lumbar, and the screws, of course, have to be smaller as well. And if they're tensioning so much at the, you're limited to the amount of tension you can use pulling a tether. So it's interesting that using a table might reduce that somewhat in terms of trying to get a better correction.
I like the concept, and I think it helps us here. But it's a really fancy spine table, and I borrow it from the downstairs spine hallway. So I mean, that's the nice thing about Mayo is we have all of the latest and greatest, and they let the pediatric spine surgeons use it too.
Excellent. Now I'd like to move from tethering to ApiFix, and you had your first well, the first ApiFix procedure with a new 200 patient study in June of this year, correct?
Yes.
Okay. What was your first, just like VBT, what was your first exposure to that particular device? Was it through studies as well?
No, I think I was actually contacted at one of the Scoliosis Research Society meetings 3 or 4 years ago by basically the company and company representatives. And potentially that was due to the Tether interest. And then it's been a long wait. I mean, they've been trying to get FDA approval for years. And then FDA approval finally came a year ago, and then we put in the first US device in June. ApiFix has been extremely strict. So the company reviews each radiograph and gives their opinion as to whether that's an appropriate curve pattern for the device. And then before they would allow the device to be used, every site using the device has to have the ability to enter the patient in a registry. So unlike the Tether device that's currently approved in the US, every single patient has to be offered enrollment in a registry for ApiFix. They can say no, and then they can still get the ApiFix, but they have to be offered it.
I see. Have you done any more ApiFix surgeries since the initial one?
Not yet.
Okay.
Not
Very
yet.
strict parameters, eh?
It is. I've submitted maybe 40 cases, and I've had one that was good and several that were intermediate rating. And for now, I'm just kind of holding off on the intermediate rating ones.
Yes, you want the greatest chance of success.
Exactly, exactly. I brought little models I can show. Yes. Do you want to see my models? Yeah.
I would love it.
So again, this was the fusion. We have to start with the tried and true. And the fusion works really well, but does not provide any mobility because there's rods. And most people who have a fusion, again, this is kind of the worst case scenario for the C-section ladies, right? If you're fused to L3 or L4, but most time the fusion is stopping for a thoracic curve, hopefully in the thoracic spine, or maybe L1. But I mean, most of your, again, this is the thing that we've all said for the last 40 years, most of your spine motion comes through your lumbar spine. So if you fuse the thoracic spine, there's no problem. That's what we say. And for the most part, it seems to be true. I mean, patients with a thoracic fusion go back to sports and seem to do pretty well. Then the tether we talked about also. This is Denesis screws. I don't have the FDA approved one, and this is now off the market. But again, this is a cord, and the cords are connected to the screw with a set screw. And you can see forward to back, it can move a lot. Side to side, and I think I can see this clinically with the patient. Side to side, they don't bend quite as much this way. They can bend that way, but they don't bend quite as much that way. And then the final axial plane, is rotation. And nobody really knows. We just got a grant at Mayo to put tethers in our engineering lab on models and do some of these three-dimensional testing on models of the tether and looking at spine motion. So that they'll have more data in a year on that. And there is some data in the literature already. And then ApiFix. So this is the ApiFix device. So the tether goes in through the side, right? There's incisions on your side. And the tether goes through the front of the spine, close to the lung. The ApiFix is more like a fusion, so it's going to go in the back of the spine. And this is the device. There's a little ratchet, so this can ratchet longer. And it provides mobility through this ball bearing at the top and the ball bearing at the bottom. And this is connected to 2 screws at the top. And then I have a model of it in the body as well. Here we go. It's hard to see. There we go. And they're saying 40% of normal spine motion with ApiFix. And then the ball bearing is covered with some kind of ceramic, super hard coating, so it shouldn't cause wear.
Yeah, it's pretty interesting. I know that initially ApiFix was maybe 2 to 3 to 4 levels. Now it's going maybe 5 to 7, but they're using, instead of just 1 screw at each end, 2 at one and 2 screws at one end, 1 at the other, or doubling up. when you installed the device, which parameters did you use for that?
Yeah, and the original FDA approval was, again, one bolt at the top, one bolt at the
Okay.
bottom. Then they got an addendum to their FDA approval, 2 screws at the top, 1 bolt at the bottom. So that's what we did, 2 screws at the top, 1 bolt at the bottom. I think the problem with this is if you put the device in, the spine is still moving. The spine has more mobility in it than the device does. So it puts stress on the system. And as you said earlier, the higher up the spine you go, the smaller the anatomy. So I think 2 screws are needed at the top to avoid failure. 1 screw at the bottom maybe is enough.
Right.
The device hasn't really broken. I mean, there's very few breakages. I think the bigger problem is controlling the deformity with that limited fixation and then pull out so the screws can pull out of the spine.
Right. Because I know with some of the where the 2 screws are and the 2 vertebrae, there's some instances of a single level fusion as well. Is that mandatory when you do the 2 screws?
I would recommend it. Again, the ApiFix is similar to the growing rods that we've been doing for early onset scoliosis for children under age 10 for many years. And it really seems, again, particularly at the top, you need a little fusion bed to hold the whole thing together and prevent failures. So yeah, and the other actually good thing in the US, I don't know how all this is approved in Canada, but in the US, adding that fusion code really helps insurance companies recommend that, to cover it. Yeah, basically it appears that it's an established procedure. Whereas for the Tether, there is no standalone code right now. And so the insurance billing can be a little more complicated because at least at Mayo, we bill an unlisted spine code.
Gotcha. So there's
a little challenge at times.
Yeah, more room for interpretation, I guess.
We've been highly successful. I mean, I think we've had 95% of them covered, but it does require some legwork on my end at times.
Okay. Now, with respect to that single level fusion, when you do the 2 screws at the top, of course, it's done at the same time. How is the actual fusion of just one level done?
Again, for the ApiFix, instead of, again, for a fusion, we expose both sides of the spine. So we make an incision in the middle and we move all the muscle off both sides. And then we can see everything and place the screws. And then at the end of the case, we roughen up the bone with either a burr or some type of sharp device. And that creates a little bit of bleeding and a little bit of those bone cells, those osteocytes, jump out of the bone and run around and they think they've been fractured. So they say, oh no, we had a fracture. We need to heal. So all those osteocytes go to work and they heal into a solid sheet of bone, and that's what a fusion is. So for the ApiFix, we're just exposing half of the spine and we don't take out any of the joints. And actually, I would recommend kind of an extra periosteal dissection. So you leave like a real thin covering of soft tissue over the bone, so it's not going to fuse. And then just at that one spot at the top, burr the bone over the back part of the spine, and just at this one little level, just like this, that's the only part you get to fuse. So, but usually children fuse pretty well. I mean, that's one argument, I think, as far as why do people need scoliosis treatment as a teenager compared to when they're 40. For fusion surgeries, children have better physiology.
It makes sense. Well, with the standard posterior fusion where you use the rods and the pedicle screws, with the ApiFix, with the 2 screws and the extender, is that what takes the place of a rod in terms of limiting motion?
It is. Okay. It is. And then this is the motion you get, again, this little wiggle. And I think that's one thing that makes the ApiFix technically demanding and why the company is being so picky is you really just need the right architecture to allow for that motion to still be achieved. But I'd like to see bending films. There's a handful of bending films I've seen, but I'd really like to see bending films on all the ApiFix patients at 1 year over the level of the instrumentation and see if it moves.
Absolutely. You need your data.
Sorry.
Oh, You do. We all need the
You
data.
do, you do. Well, I mean, if you're going to go and put through someone, I mean, there's higher reoperation rates. I mean,
Hmm.
Tether and ApiFix have a higher reoperation rate, to the best of our knowledge, at the current state of time compared to a fusion. So if you're going to expose an adolescent to a higher reoperation rate, we want to make sure there's some benefit that's being achieved. You could argue faster recovery. I mean, both Tether and ApiFix probably have a faster recovery, so maybe that's enough benefit, but ideally we're providing some functional benefit as well, some motion.
If we go back a little bit to the parameters of the study for ApiFix and what you're looking for, have you kind of realized now after doing 40 submissions what they're looking for in terms of approving it
I think
optimally?
so. I think so. I think they'd like for me to be submitting younger patients, and for now I'm mainly submitting older patients that I feel are too old for a tether.
Mm-hmm.
And it may be that many of the older patients just don't have enough flexibility for the ApiFix. So they're looking for a single 60-degree curve or less, and it needs to bend out on a bending film to less than 30 degrees. And then on the side view, they don't want too much kyphosis, which makes sense. If you have a lot of rounding, this thing's not going to fit in there very well. I mean, they want a pretty flat back to begin with, because this device is not going to accommodate a lot of kyphosis.
Right. Because I was looking at a study that was just released recently as well in terms of ApiFix and for immature spines, because initially I was also thinking it would help with the mature spines who've missed that DBT window. And it seemed to indicate that there has been apparent bone growth modulation with ApiFix device being installed for immature spines. What's your perspective on that?
I haven't read that new study. I guess I don't know if it's growth modulation, right? Growth modulation, do you have to tether from the front? I can imagine the wedges improved, right?
Mm-hmm.
So if you had a big wedged curve and you had a 80-degree curve and you took it to 40, or 60-degree curve and you took it to 30 with ApiFix, then those wedges are going to be, hopefully grow back to being square again.
Right.
Yeah, I guess I have to think about the terminology a little bit as far as growth modulation. I almost think of the ApiFix more like a growing rod or a Shilla. It's very similar to a Shilla, where you fix the top, you fix the bottom, and it's going to grow with the child. But it has the advantage of ratcheting, so it can't get shorter. It has to get longer or maintain.
Okay.
I think it might be great as a growing rod. Unfortunately, it's a little big maybe, but actually I held it side by side with a magnetically controlled growing rod. It's about the same size as a magnetically controlled growing rod.
Okay.
So I think ApiFix has a role.
Mm-hmm.
Again, it's very new to the US, 400 cases maybe in Europe.
Yes.
So I think we're just kind of waiting to see how it fits into our practice.
Fair enough. With ApiFix, I know that they're recommending as much as correction as possible on the table. Previously, they were, I guess, not correcting as much, and they were hoping for growth and the ratcheting to help with greater degree improvement. Do you also have a table? I guess everyone has a table these days that tractions for the ApiFix patients, or do you use that similar table that you use for tethering?
Again, we've just done one case, so I can't really give you a full accounting, but we had that table ready to go, but we decided at the end of the day we didn't want to stress the system and stress the device and stress the patient, so we just basically took what we could get with the distractor interoperatively.
Fair enough. And I guess your perspective on the ApiFix was you were hoping to also use that for more mature spines eventually.
That's still my indication right now. And there is no age limit. I mean, the FDA approval is anyone as far as age goes. So so I think that's kind of my preferred target population right now for ApiFix, for people who, for whatever reason, don't want to have a surgery on the front of the chest. Some people maybe can't, right? If you have terrible asthma, or if you only have one lung, or I mean, for whatever reason, if you don't want surgery next to your lung, I think it's a good approach. And I think typically for older children who've lost that tether window. And what are the other advantages? Technically, I think it's going to be easier for orthopedic surgeons to do. it's a variation on a theme of what we already do all the time. So it'll be
treatment.
technically easier. Yes, exactly.
Okay. One final question with respect to ApiFix. When can you actually, does the study limit you to doing the device installation for a little bit more immature spines right now? When are you able to actually use it on more mature patients, I guess, is the question.
Again, currently, right now, with the FDA approval, there's no age limitation on the ApiFix. And I think as far as my personal experience as a surgeon, we have pretty good track record with the Tether. So right now I'm going to kind of wait and see how these older patients do with ApiFix. And then obviously if I have a younger patient that comes in with a strong preference for ApiFix, I'd be happy to do it. But I feel like we've had, again, a bit more experience in the US with the Tether, a bit more data demonstrating motion preservation. And so I guess that'd be my preferred approach for a younger child who's a candidate. But a lot needs to be determined, right? I mean, we're very early on in this progress, and we'll know more in a year from now. So I think you should check back in.
Okay, let's do that. Final question. If you're going to look into your crystal ball 10, 15, 20 years down the line, what do you see in terms of the horizon for scoliosis surgery?
I would like super early detection. So again, some kind of crowdsourced early detection of scoliosis and metabolic treatment with calcium and vitamin D and maybe physical therapy and some kind of targeted bracing, not brace 5 children for every 1 surgery that's avoided, but targeted bracing where we do aggressive bracing for a brief period of time. Maybe some type of dynamic bracing. Again, the Montreal group has a little bit of data that it's not just loading, it's repetitive loading. So I mean, potentially we can get in, if it's got some type of dynamic brace, maybe we could get in 18 hours of brace wear in 3 hours, you know, if we loaded the growth plate just right. And then for scoliosis treatment, I think we need some kind of biologic that we inject and quit putting rods and screws and plastic in our patients. You have to dream big. Put me out of business. That's my goal.
The surgeons I like to talk to are the ones that, yes, we're finding a cure, and that's what my goal is, all right? So why not shoot for 100%? I like that.
Well, it's ambitious, but I think for now, you're right. We're doing the little piecemeal steps, and we're working with what we have, and really we've seen kind of the first major intellectual advancements, I'd say, in scoliosis treatment in the last couple of decades. I mean, it's a very exciting time to be involved, to have new treatment approaches instead of the fusion.
Okay. Dr. Larson, thanks so much for granting this interview, and I really appreciate the information you've shared with the viewers. Thank you so much.
My pleasure. My pleasure. Thank you so much.
Okay.